pandemic was declared by the WHO on the 11th of March. And that was, just before things really closed down here in 2020 in Ontario. And then shortly after that, by the end of March, there were announcements about the CERB, or direct financial supports of approximately $2,000 to individuals who met certain criteria. And although there was some confusion, mostly around the eligibility criteria, that led subsequently to some people being asked to repay these benefits, I think overall, my impression that I'll argue, and I'm looking forward to the discussion period, is that it was technically a success, that the federal government was actually able to drop into individual checking accounts $2,000 each month. And, although obviously there were some instances of errors and fraud that happened, overall, I believe that what we saw during the pandemic was positive, in the sense that the government could very quickly get money into people's bank accounts. And of course, I'm speaking to you today from a health center in inner city Toronto, where there would be a lot of people who don't have bank accounts, and there are some technical challenges. But overall, I think we learned during the pandemic that the government can provide supports to individuals. And that's my focus today. And we'll come back to this a little bit later, but I just wanted to also flag to you here briefly that a large part of the financial measures that were brought into force during the pandemic were not cash transfers to individuals. Actually, a large amount of the money was directed towards supporting businesses and supporting even some entire sectors, as the federal government outlines their supports on their website. And we can discuss that a little bit later on. Now, to the second point, in terms of the acceptability of these cash transfers, this image here is from the Freedom Convoy, and there were a lot of different concerns or complaints of people who were participating in the Freedom Convoy. Obviously, one of them was vaccine mandates and vaccine passports. At the time, there were others around masking. And of course, one of the important threads through the Freedom Convoy was proponents of white supremacy and racism, who had certain concerns about being oppressed during the pandemic in various ways. What I want to note here, without commenting on the validity of those concerns or in too much detail about the Freedom Convoy at all, is that as far as I could see, there weren't really a lot of concerns about these financial supports or cash transfers to individuals by the Freedom Convoy participants or by others, actually. And overall, I would say that what we saw during the pandemic is, even when a large number of people descended on Ottawa with wide-ranging concerns on various topics, there wasn't a big outcry, by my reckoning, against the CERB or other financial measures that supported individuals. So, and I think maybe the way I'm reading these survey results from Angus Reid, which is a polling institution, when they did this survey in October of 2021, just looking at sort of the, the high level summary here, this 41% in the left bar at the bottom of the left bar here, we're saying at that point that financial supports like the CRB could be ended, meaning that still the majority of people at that point in the pandemic, October of 2021, were okay with them continuing. And obviously, as you might expect, among those who were receiving these sorts of financial supports, there's a greater proportion who supported them. So if you are looking at these sorts of poll results, I think this would be an example of the type of measure that's not raising a huge allergic reaction to people. And although the circumstances were fairly extreme during the pandemic, I believe that what we can take from this is that overall, direct financial supports to individuals are mostly acceptable in Canada. Now, what I want to spend most of the time here today talking about is what are the effects, especially the health effects of providing people with cash transfers. The pandemic saw unprecedented attention to inequities, and media outlets across the spectrum, reported on disparities in COVID-related deaths, COVID infections, and later on during the pandemic in COVID vaccine rates. And even the Toronto Sun, if you've heard about it, ran a column about a tale of two pandemics, although the disparities they were talking about there were maybe a little bit different from the other outlets shown. At the same time, as the Prime Minister said, we are all in this together. There were temporary foreign workers who were living in really unsafe, crowded housing, even during outbreaks on these farms, especially in Southern Ontario. The Premier of Ontario said we're all in this together, but at the same time, never provided paid sick leave of a duration that would have addressed the spread of this virus that causes a cough. The Mayor of Toronto said we're all in this together, but encampments for people experiencing homelessness were violently cleared during the pandemic. You could tell from this image that the individual pictured is giving a speech about the cost of living crisis in the United Kingdom. And this speech was given back in the spring when he was merely a prince. And since then, the cost of living crisis has only gotten worse. And this individual is now meeting with a new prime minister who may bring in a new era of austerity in the United Kingdom. And I think, despite all of the talk about us all being in this together and about the importance of attending to inequities, I think there's actually a possibility that we could see things getting worse going out of the pandemic, and there being what's termed a K-shaped recovery, where disparities and inequities worsen or are exacerbated, and the fates of people who are privileged and those who are disadvantaged could diverge even further apart than today. So we sought as a group, including Professor Dunn, to review the literature and identify policy changes or interventions that could address health inequities during the pandemic recovery period when the immediate threats of the virus abate. And most of the findings I'll be talking about are based on systematic reviews of studies that were completed prior to the pandemic. And we made a total of 13 recommendations. I'm going to focus on the ones related to income here today, and I'll just mention a few others. So that the first recommendation that I'll spend some time on today is we recommended cash transfers that would ensure a living income, allowing people to afford basic necessities like food. And that was based on several systematic reviews, including one of 21 studies, including a dozen trials that were done, mostly in low and middle income countries, that have found health benefits, especially in children and women, but including in infant mortality rates and in general self-reported healthcare utilization, all of providing income supports directly to individuals. There are also, as you might know, several observational studies that have been done in high-income countries. One example would be the MINCOM study that was done in Manitoba that showed benefits of providing financial supports to individuals. And one of the effects was that there wasn't any decrease in employment rates that was registered in that study. And that is one of the concerns that sometimes levied against these studies or these interventions that involve cash transfers to individuals, that would decrease the motivation to work. So I say those were all studies that were done prior to the pandemic. During the pandemic, we actually did a study here at St. Michael's Hospital of providing people with a cash transfer. And if you don't mind, I'll spend a few minutes describing it for you right now. So as I mentioned before, that people were differentially affected by pandemic-related restrictions, and others have pointed out that those who would have less assets, like less savings, and a lower income would have been disproportionately affected by pandemic-related restrictions and may have found themselves unable to afford basic necessities. And I think particularly people working in the manufacturing industry, light industry, individuals like taxi drivers would have been very badly affected. So we sought to recruit individuals who would be maybe among the worst affected by pandemic-related restrictions, and do a randomized control trial where we could measure the effects of providing people with a cash transfer. And one of the motivations for doing so was even with, what would be the typical CERB amount to a family with, I believe that's 3 children, it would be below what's the government reported cost of living in Toronto right now. And there are, we don't need to get into all of the details of who is eligible or not, but not everyone who would benefit from the CERB was actually able to receive it. And there were some other interventions that helped to inform this work, including the amount that we provided, and that included a basic income pilot that was done in Finland, and some of the work that had gone into the canceled pilot in Ontario. So this, for the academics out there, I still get teary-eyed thinking about how quickly we were able to move from a proposal to a project. So we submitted to the Research Ethics Board this protocol on the 23rd of March in 2020. And we actually got approval less than a month later, and we're recruiting patients less than 1 month after making our first submission to the Research Ethics Board here at St. Michael's Hospital. And the whole study was completed by May of 2020. But the main point of the slide actually is just to show that we were measuring the effects of cash transfer very early in the pandemic, when people were still recalibrating in many ways. And the inclusion criteria were fairly simple. So we asked a standard validated question about the ability to make ends meet or afford basic necessities like food and transportation, except we added a twist, which was that it had to be due to COVID. So due to a COVID-related restriction or due to COVID-related illnesses that would have affected the person or their household income. So anyone who said that they couldn't afford basic necessities due to COVID was eligible to participate. We did specifically reach out to some organizations that support or employ personal support workers who were in many cases engaged in very dangerous work at this time when personal support workers were not generally offered all of their personal protective equipment that they probably should have been. And some personal support workers, I understand, felt pressured to take on jobs that they understood to be dangerous. And we also reached out through certain organizations that support taxi drivers in order to enroll other individuals who had their income affected in that way. And we provided people with $1,000, and we accommodated, in most cases, we transferred the money into a bank account, but we could accommodate people who did not have a bank account, and provided them with a single cash transfer of $1,000. Over 14 days, we followed them, and the main primary outcome for this study was symptoms of COVID, and we based our symptom list on a validated instrument that had been developed for the flu. And in both groups, we provided them with the general public health recommendations from the Public Health Agency of Canada about physical or social distancing, and avoiding close contacts greater than 15 minutes where possible. So both groups were provided with that very same advice, so we ended up approaching 491 individuals. We randomized 392. 196 to the control group who just got the advice, and 196 to the group who got the cash transfer and the advice about physical distancing. And I mean, one thing to note from the baseline characteristics in this study that might be of interest is just that I think we enrolled a disproportionate number of racialized individuals, probably through our outreach to the personal support workers and taxi drivers. And the majority of people under ordinary circumstances had derived their income from wages, and most of them were low-income individuals with an income below $30,000. And as you see, we did not exclude people who received any COVID-related income supports, including the CERB, provided that they still reported an inability to make ends meet. So even with whatever supports they were receiving, whether it was COVID-related income supports or ordinary social assistance that existed prior to the pandemic, they were eligible to participate if they still had trouble making ends meet. And so the main result was, let me just explain this, this forest plot here. So this is showing the results of the COVID symptoms over the 14 days. And the vertical line here at 1.0, that would represent no difference between the cash transfer or the information only. And anything to the left of the line indicates that the cash transfer group did better. Anything to the right of the vertical line means that the information only group or the control group did better. So you can see overall in terms of COVID symptoms, there's not a statistically significant difference between the groups. There's maybe a slight trend towards fewer symptoms reported in those who received the cash transfer. We had pre-specified a subgroup analysis looking at older versus younger individuals. And for those younger than 50, there wasn't any substantial difference. But for those who were older than 50, and note, 50 is not old, so I'm not saying those are old individuals, I'm just saying older than 50, there was a reduction in the reported COVID symptoms. There wasn't a difference between women and men in the effect of the intervention. So overall, no statistically significant difference in the primary outcome of COVID symptoms, but a benefit registered for those who were older than 50. And Other outcomes that we measured, there wasn't a difference. So at that time, PCR testing was not widely available, even for research purposes. Like for interventional studies, it was very difficult to obtain the materials needed for PCR testing. It was also difficult to arrange for PCR testing to be done for research purposes during that very early phase of the pandemic. So we did not routinely administer PCR tests, and we did not seek to confirm COVID diagnoses with PCR testing. And you can see that in each group, only one participant actually tested positive by PCR testing, which is obviously an underestimate of the number of people who truly would have had COVID during that period. There wasn't any statistically significant difference in the number of close contacts in general health that was reported, in the ability to make ends meet, in food security or food insecurity, or in adherence to medications. But recall, these are outcomes were all measured after just 14 days. So this was just 2 weeks after receiving a single cash transfer. And that is probably one of the biggest, if not the most important limitation of the study. Is we had a view when we very quickly started this study that we would be measuring the effects of monthly cash transfers for a period of at least 3 months, and we were actually hoping for 6 months or longer, but the funding to continue the trial never actually materialized. So we can only really comment on the very short term, the 2-week effects of this cash transfer. And I'm not going to go on a big speech about this because it's boring to hear an academic say that their own interests should receive more funding from the government. But I will note that subsequently to completing this study, like in this organization here, we have, and I'm pleased to be a member of groups that have received large amounts of funding, like millions of dollars for funding of research studies, especially for those related to therapeutics. And, you know, the amount of money that is put into measuring the effects of something like a cash transfer is actually surprisingly small. And I think that's remarkable, partly because of the cost of the intervention here would be measured in the billions of dollars. And the other remarkable thing about this study, and this, again, maybe I'm not trying to boast here, but making more of a comment about the literature and maybe about what gets supported in academia, we did as part of that review a fairly systematic search to try and identify other studies conducted during the COVID pandemic of cash transfers and the effects on health, including on the spread of COVID. And actually, we did not identify a single other study where individuals were provided with a cash transfer and then their health was measured. And we know that here in Canada, in other high-income countries, like in the United States and in the United Kingdom, there were billions or trillions of dollars spent on cash transfers to individuals. And I think, you know, one of the sad parts moving out of the pandemic is we actually don't know what were the effects, whereas I think we could have known if more thought was put into to studying that intervention when it was being administered. And I believe it would have been possible to both provide income supports very quickly and to measure the effects. And that's something that we can discuss later on. So yeah, everything I've said so far is mostly related to that first recommendation about cash transfers being provided to people. And I just want to briefly mention a few of our other recommendations that are relevant here. So first of all, and this is, again, is based mostly on, exclusively actually, on studies done prior to the pandemic. They showed that measures like sick leave and unemployment insurance are beneficial. And so, for example, there were a number of studies that showed that paid sick leave reduced the spread of influenza, which was, like, you know, the main condition where non-pharmaceutical interventions have been studied prior to the pandemic. So providing people with paid sick leave reduces the likelihood that they attend work when they're sick and reduces the likelihood of missing work, among others. So we made a recommendation about supports for people who are employed where their employment is interrupted. The third recommendation and final recommendation about income that we made was about low-income loans or affordable credit. A very large number of studies have been done in low and middle income countries showing health benefits of providing people with low-income loans. The term that's used there is microfinancing, and there are various microfinance models. Some are primarily just providing people with loans. Others are providing a number of supports or placing a number of requirements on that loan, including participation in educational programs or joining with a group or forming a business collective with a group. But if you pool all of those studies together, and even if you focus on just the pure loans, there are clear benefits, especially in terms of child health and in the health of women. And the Grameen Bank, that won the Nobel Prize for this microfinance model, is currently operating in the United States, providing low interest loans or affordable credit to individuals in the United States who meet certain criteria. But here in Canada, credit is very expensive for low-income individuals, and most people who are termed unbanked, who don't have a bank account, wouldn't qualify for most loans offered by a bank, turn to payday loan institutions that can become a poverty trap. So generally speaking, you have to pay administrative fees and other charges if you don't pay back a loan over a certain period of time, and many people can end up never paying back the loan, and if they do, they're paying back many times more than the amount that they initially borrowed. So I'm going to wrap up soon, but I just wanted to mention a few other recommendations that we made that I think are relevant to the cash transfers. So first of all, publicly funded childcare. There are several randomized control trials, including a handful that are done in high-income countries, showing that providing publicly funded, affordable childcare has health benefits for both for children and increases workplace participation for parents, especially for women. And the flip side of that is you can just imagine how the cost of daycare or childcare can be crippling to families, and how it could really be the difference between parents being able to afford enough food for them to eat or not. Just our 12th recommendation was about including prescription medicines in our publicly funded healthcare system, or implementing national pharmacare. And I just wanted to briefly mention that we did a study of providing people, this is prior to the pandemic, with free access to medicines. And we registered a number of benefits of doing that. This is in people who reported not being able to afford their medicines, some improvements in surrogate health outcomes, like short-term control of diabetes. But actually, the main benefit that we saw, the largest benefit that we saw, was a large difference, an absolute increase of 53% in the ability to make ends meet or afford basic necessities. And this is true despite the fact that in many instances, the costs that we were saving people would have been on the order of like $30 or $50 per month. So eliminating a relatively small amount of someone's expenses can be the difference between them affording their rent or not. The last recommendation I'll mention here before wrapping up is that instead of making a new recommendation about addressing racism, we pointed to previous reports and recommendations that had been made, including in the 1990s, and some of those expressed, quote, bewilderment at why previous recommendations, like going back now to the 70s and 80s, had not been implemented. So I'll just mention here that one connection to cash transfers is, I think, similar to other interventions like publicly funding access to medicines here in Canada or publicly funding healthcare in the United States. Part of the reason these are opposed is because of racism, is because there'd be a contingent in society that doesn't like the idea of racialized people having access to these things, or there'd be this feeling that certain people don't want to pay for healthcare that's received by racialized people. And I think that would also be an impediment to cash transfers or a basic income, which is this feeling that some people would not want to support others. So my take here is that we learned during the pandemic that cash transfers to individuals are doable, that they're generally acceptable. I'm definitely not saying universally supported or unanimously supported, but I think overall acceptable. And I think although there are, a lot of unanswered questions, frustratingly, despite everything that happened during the pandemic, I think overall, based on what we knew before the pandemic and what we saw during the pandemic, is that, likely there is a benefit of these cash transfers, including probably on the spread of diseases like COVID-19. Clearly, we need more studies of the longer term effects of cash transfers, like in settings like where we are right now in Ontario. I would actually really appreciate if someone who knew more about this issue of the supports to businesses, you could do a little bit of a comparison of the amount of money that was invested in supporting businesses, that those funds were indirectly supposed to get to individuals. So some of the business supports were meant to go to businesses, and then they were supposed to disperse those funds to their employees or their former employees. But I would like some accounting of how much money was spent on those programs, where the money actually ended up, and what are the effects of that money that we can point to today, and some comparison then with the cost of the cash transfers to individuals. And we have some information about what might be the effects of them. I think there are some potential harms of providing cash transfers, and I think that is something that, if it had been better studied during the pandemic, we'd have some more information about. And I do think it's extremely important, like both from an academic perspective, but also in terms of informing public policy, that we are careful to measure unintended consequences of cash transfers. And then, as I gray a little bit here over time, I am seeing things as a little bit more complicated. Like the patients who come into this room here, they usually don't just have one problem. And, I used to think that like for my patients with diabetes, providing them with free access to diabetes treatments would solve their problems. And now I see, participants in that study I was mentioning, they came back and said, yeah, it's great. I don't have to pay for my diabetes medications anymore, but I am still eating canned pasta from the food bank, and I know it's bad for my diabetes. So, I think maybe the most interesting question to answer going forward is, how do supports like direct cash transfers interact with other supports like publicly funded medicines, like access to healthy foods, especially for children? And these are some of the resources, and I can share in the chat some of these URLs. And I am really looking forward to the discussion. Thank you very much.
Well, thanks very much for that, Nav. That was a fantastic talk, and you gave us a lot to think about. The one thing that you had pointed to that stuck out for me was the question that you raised about supports to individuals versus supports to businesses, and And so, yeah, that sounds like a pretty complicated thing to try to assess, right? Because as I understand it, part of it was just to make sure that the jobs were still there and the businesses still existed after time. But I guess what are the right conditions to put on those is probably one of the best questions. But yeah, I mean, enough of me talking, and thank you for your thoughts. Let's open up the floor now to any questions or comments from our sizable audience. Thanks for being here, everyone. Tina Moffat. I see Tina Moffat, who would like to ask a question. Please, Tina, fire away.
Hi, can you hear me? I can't, for some reason, I can't undo my video, so that's okay.
That's okay.
As long as you
Yeah,
can
we
hear
can
me.
hear you.
Yeah, thank you for a very interesting talk. I'm really pleased to see this discussion happening in light of all that we've learned from COVID, and your research has really shown the impact of the income transfers. I study food insecurity, and I guess, you know, I'm thinking about comparisons between Canada and the US. So we have traditionally done income transfers in Canada versus the US, which tends to do the, you know, targeted food programs like food stamps and women and infant children program and so forth, school meal program, national school meal program. And I think what you're saying today is that, you know, it doesn't necessarily have to be either or, right? Because there's a lot of debate in Canada and among food security folks that, you know, it's really, you know, people say, most of the advocates say it's better just to do cash transfers, because food insecurity is not a food problem, it's an income problem. But on the other hand, we're not really doing well with food insecurity here in Canada, and it seems to be getting worse. So I wonder if you could you just maybe speak to some of this debate and the either or situation.
Sure. Yeah. I mean, before I comment about food insecurity, let me just say I'm biased because of my perspective on medication costs. So there, I think it's pretty clear that because not everyone has the same medication costs, that medication costs should be insured, so that, you know, a person with diabetes on expensive medicines, you know, shouldn't have to be paying, you know, $100 or $200 a month to be healthy. So most people accept that, although even in that, for that issue, we don't actually have public funding for outpatient medicines. You know, so some of my thinking about that transfers to food insecurity, where I think, yeah, obviously in an ideal world, everyone would have a sufficient income to afford healthy foods. Although there's less of a difference in terms of, you know, household costs for food versus household costs for medications, which can really vary wildly for different households in the case of medications, but less so for food. There are certainly differences, and so, for example, the direct link between your health and the food you consume is going to be greater for someone with diabetes, for example. So, to my mind, I think we should be doing both, providing income supports. And I am actually, you know, looking at the literature from these, you know, food stamp or the SNAP program in the United States. Generally, the studies show that they are beneficial, like they do reduce food insecurity. I didn't mention our recommendation about food provision in schools, but generally speaking, they are beneficial. They improve school attendance, they improve school performance, and they have some benefits in terms of if health too, reducing the likelihood of obesity in certain situations for children. So yes, I'm familiar with the other view that really we should just be focusing solely on income. The other thing I would say is we do have to be realistic. We live in a province where there was an announcement that there would be a basic income pilot. The basic income pilot started. There was a question during an election about whether a new government would cancel the basic income pilot. The answer was no, we're not going to cancel it. then the basic income pilot was in fact canceled. So, if you are a family that experiences food insecurity, or if you're a family doctor who tries to help people who are experiencing food insecurity, like, what should you be saying in the meantime? Let's just wait for the income problem to be solved. I also don't necessarily think it's true that if we provide more supports when it comes to food insecurity, that will be an argument against a basic income or providing cash transfers. But I'm sure there would be different views on that point as well.
Thank you.
Thanks for that, Nav. And yeah, I think the one little nugget that I heard in your answer was, and I'm sure there's many others in a more fulsome examination of this, was that to answer Tina's question, yet probably both might actually be beneficial. For example, as you said, food, breakfast programs and meal programs at schools actually improve school attendance. Income alone wouldn't do that, is unlikely to do that, right? But actually having the program does. So that's an interesting finding in itself. Any other questions or comments? I'm scanning, I have 2 pages worth. Laura Anderson, please go ahead.
Hi, thank you, Nav. Great presentation. Oh, I can start my video, it says. I really enjoyed hearing about this, great work. It looked like in the slide where you showed the descriptive stats on your population that only about 30% were eligible for the government benefits that were provided. Can you comment on that? Is that what you would have expected?
Yeah, it was 30 were of those who met the eligibility criteria for the trial were actually receiving a government support related to COVID at the time, like the CERB. Yeah, that was around what we were expecting. First of all, it is possible, I mean, I think it's quite likely that the supports like the CERB did provide a sufficient income supplement for people. So some people would not be eligible for our trial because they were receiving the CERB, in the sense that they were then able, because of the supports they were receiving, to afford basic necessities or make ends meet. And that would therefore make them ineligible for our study. It's also possible, this was very early, and so some of the people in our study might just not have been signed up for the CERB yet. So they would have been individuals who in the future were going to benefit from the CERB. So yeah, it was around what we expected. Similarly in our study of free access to medicines, we did have a number of individuals, like more than 10%, who actually received, who were publicly insured for medicines, but for a variety of reasons, including administrative reasons like losing a drug card, etc., were still unable to afford medicine. So some of those sorts of administrative reasons might also apply to individuals who were actually receiving a government support related to COVID.
I guess that's kind of what I was wondering. How many, do you think everyone in your study should have been eligible for CERB, or not necessarily?
No, it's not necessarily true that everyone would have been eligible for CERB. So some of the people who might not have been eligible were individuals with a relatively higher income. So we didn't have any very high income individuals in our study, but we did have some with a higher income, but they also would have had higher household expenses, potentially because of a household member with special needs.
Okay, thanks for that, Nav. And thanks for the question, Laura. Any other questions or comments from the audience today? Okay, well, I'll take chair's prerogative and ask one. So, Nav, do you know of much literature that actually looks at the elasticity of some household expenses and their relative influence on health? So I'm thinking, when you gave the drug example, it made me think of that's essentially people can opt out of actually filling their prescriptions and taking the medicines that they need, but many people will actually reduce expenditures in other areas in order to fulfill that one. And then, of course, you know about my interest in housing. And one of the things that I find really interesting about housing as a potential influence on the relationship between income and health is that it's fairly inelastic, in the sense that if you have an apartment that has 600 square feet, if money's tight in February, you can't say, well, I'm just going to occupy 400 square feet this month in order to save a third of the rent. Are there other expenditures that you think have this kind of inelastic component to them that might be helpful in terms of interventions? You know, medicines and rent actually come to mind for me, but do you know of others?
Yeah, I mean, just thinking about like what are the basic necessities that we usually think of here. Like we talked about many of them already. Food, medications would be one, housing, and then transportation would be the other one. But yeah, I mean, based on my look at the literature here, for interventions that are aimed to support people with their transportation costs when like that's a barrier to being able to make ends meet. It'd probably be another one where for most low-income individuals, it's difficult to save any money because you would usually be using in a city public transportation. And if you're living rurally and you have to drive to your job, you probably don't really have a choice there, and you don't set the price of gas. So there's not usually a really good way for you to decrease your costs there. And we did a systematic review of these sorts of studies that did actually register some health improvements, for example, in providing free access to public transportation, especially for older adults, actually, in that case, over age 65.
Yeah, that's a common target group for sure. Maybe I'll go to Marissa Young next. Thanks, Marissa.
Thank you. And thank you, Nav.
Tina.
So absolutely. Thank you, Nav, for your presentation. And thank you for taking your time out of your day, which I know is obviously very important in your clinic right now. But I wanted to ask, if you don't mind, based on some of the responses to the comments you're currently providing, but what, like, us just going through this municipal election and us thinking about the different expectations that the constituents have around what politicians should prioritize, I'm wondering, what would you say out of those different recommendations? Like, could you actually put those in a queue to say this would be number one compared to otherwise? Because my first thing as a work family research scholar is always around childcare, right? But you said earlier, that definitely making sure that there is funding for prioritized medical and prescription-based services is also a priority. And so, like, I guess I'm just wondering, in that mindset, what would you say is kind of like the top priorities to kind of help solve some of the problems that we see amongst lower population individuals and families?
Thanks. It's a great question that I'm going to try to dodge.
It's a hard one, but yeah.
Yeah, look, I'll say a few things. First of all, when we were trying to format our 13 recommendations, I had first thought to mention child health first, because to me, like, as a family doctor, partly, I sort of think about that sort of chronological trajectory in someone's life and how we want to, intervene early as possible. So that was my first thought. I think others looking at it would say, it all starts with income, and income can indirectly affect all of these other issues like food security. And then I guess there were some others who said, housing is principal. Like, it all starts with housing. Like, even if someone has an income, they still need to be stably housed. So some would place that first. I've also presented these recommendations in different groups, and some have said, really, your last recommendation about racism should have been the first one, because a lot of the problems that we see today are actually rooted, like, you know, this resistance I was talking about to social supports and things like a basic income are rooted in racism. And we need to really confront that first. And then actually a lot of the problems that we're talking about, like including, you know, this concern that we don't have enough money to give children food at school, like, you know, those sorts of things will look ridiculous if we confront racism. So yeah, hopefully I've succeeded in dodging your question about which one I would rank first. But I guess, you know, my response would also be, and this is like a genuine response now and not trying to dodge the question, like, why don't we do all of them? Like, all of these interventions have been proven. Like, one of my main areas of interest is medication access. I've, you know, spent a fair amount of time on it. And like, it seemed like during the pandemic, when millions of people lost their drug coverage or their access to medicines through no fault of their own, like a very compelling argument to include medicines in our publicly funded healthcare system. You know, it hasn't happened, but, you know, all of the, you know, like, I think the argument for a basic income was also like made very obvious during the pandemic, you know, also hasn't happened.
Great. That was
Okay,
a
well,
very excellent answer to my question. Thank you very much.
thanks, Nav. The struggle continues. Okay, so last word we'll give to Tina Moffat again, and then we'll have to wrap up after that. Thanks, Tina. Great to see you now.
Hi, thanks. Yeah, I think Nav, you kind of started speaking to my question, which is there more of an appetite for things like basic income now that we've been through the pandemic? Is this the time, you know, where we might be able to make some headway with all of this, or do you think we're going back to where we were before?
Thank you. I think there's a huge opportunity, and, you know, that was the basis for these recommendations, is that, you know, there is a tension. I think, you know, this dramatic period when many people lost their jobs through no fault of their own is still like relatively salient for a large number of people. So I feel like, you know, I don't know if there will ever be a better juncture to try and advance this work than right now. So, you know, if we want to try to end on a positive note, I would say, like, you know, if there are like-minded people out there, you know, in this Zoom room, like, let's think about what we could all do together right now to try and inform and affect these changes.
Yeah.
Well, terrific. Oh, sorry. Go ahead, Tina.
No, I agree. Thank you for the call to action.
Excellent. Well, thanks again to everyone for joining us today. I think we're at our time, and we should let Dr. Persaud get back to his patients, and thank him again very, very much for these insightful comments and for stimulating a great discussion. And I'll hand it off to Lindsay to take us out to the end. Thanks again, everyone.
Thanks. Yeah, and just very briefly, as I mentioned before, we'll be able to send the video for this talk out to everybody who registered within the next couple of weeks. And I'd also like to thank Robbie Bryden and Gumrun Park from the Institute's Income Security and Health team for coming and helping to co-host the meeting today. And finally, for a quick reminder to the students in Dr. Singh's course to please reconvene on the separate Zoom link that she sent to you for the discussion after the class. And yeah, thanks very much, everyone.